Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
I don't currently have service for some reason. Testing. Test. Testing. Testing. One, two, hello, three. I've never been late for this job before. Like, what if today's the day something goes wrong?
Have a knife, scalpel, scissors, plastic kit. Under the legal limit. Even under the legal limit. Can you take this on an airplane?
Not on an airplane, but you can carry a sword if you want. Look at that, goodies.
That's right.
PR game.
That's right. Aaron said it was okay for me to make a little announcement before.
Oh, nice.
Yeah.
This is for John. He just asked if he could use it, but
Okay, if I bring up something here.
oh yes, yes, definitely. You can bring it up on this one if you want.
Is that better?
Whichever, 'cause, I think once we plug it in, yeah, it kind of takes over that screen, I think. I always forget which thing it is. According to Dr. Bichet.
How do I like scroll?
2 fingers. If you want to talk, can you show me what to point to help?
It's just gonna be real quick because I know I got a lot to go through.
Okay.
Gosh, look at all these pens.
Oh yeah.
Dang, how many are there?
And clips.
Never run out of pens. You don't need that.
Emotional support.
You got this.
Okay,
You're
cool.
just helping.
I'm just
Moral support.
Do you want to airdrop it or you have a flash drive? Or yes, with me. I'm gonna type it out here. Oh, you want to attach yours to the? Oh, okay. So we have what?
That's the newer one.
Because the problem is what connections we have here.
No, I'm
this
always
one.
like,
So if you have,
I just have
you have
HD
this.
one. I have like a new one.
But does it? What's on this side? Let's see what we have.
It's just the last time I tried to transfer it to another computer.
That will work, right?
Screwed up. No, it's
Let me see where it is. I'm just trying to see. Wait, what did you make?
huh?
Did you make a keynote? Let's try it. It might work.
Okay, we can try it. Okay, I've never airdropped. Does that work?
No.
This is your first time?
I feel like I shouldn't airdrop in front of you.
Just kind of turn your back.
Nobody look. We're airdropping.
Okay.
Okay, so that's that.
I want people to focus on this one. Who you don't. Okay, good. Is Doug Sure. You should be. Thought would you mind doing that? Especially since I'm talking. 5 minutes in. You join the count?
Sorry, just a second.
Do you want me to start talking while you guys
You are? Huh?
I'll make it quick.
If you can, you're welcome to start talking now.
Oh, this is weird. Hello? Good morning, dermatology, and welcome to Grand Rounds March Madness 2020. I wanted to make a quick announcement before things get started about the podcast. Thank you. So, as many of you probably know, I co-host a podcast that the department supports. It's called Dermosphere, and we'll load up a little update. I thought you guys might be interested. And because this is before the meeting, I also wanted to enlist anybody who considers themselves a fan of Dermosphere or a fan of Luke Johnson. Thank you. You don't have to actually identify yourselves in front of everyone. But I have here a box of about 480 Dermosphere pens. You're welcome to come up, take one for yourself, take a handful, hand them out to people who you think might be interested, and also a bag of buttons that say, "Ask me about Dermosphere, the Dermatology Podcast." So if you feel like you want to be asked about Dermosphere, the Dermatology Podcast, and consider wearing one of these perhaps around AAD. And if you're wondering where you can direct people, you can tell them dermospherepodcast.com is a good place to go. And of course, they can actually download the podcast wherever they get their podcasts, such as Apple Podcasts. I feel like I'm saying the word podcast a lot. And I just wanted to give you guys an update on what's going on with the podcast, if we can get it up and running. But we release an episode every 2 weeks, and we have 21 episodes so far, and episode 22 is going to come out on Monday, and I believe will feature a couple of the residents from our program. So we've been going on for 9 to 10 months, so almost a year, and you can't see this. Oh, but maybe you're about to. We have some analytics. There we go. So here's Dermosphere, the website that we use. We have almost 10,000 total listens, and it estimates our audience at 493, and we are continuing to be proudly unsponsored, but if a pharmaceutical company shows up, I can quickly change my tune. And then this allows you to see a lot of other metrics, like where people listen. Interestingly, like 20% of our listenership is international, which is kind of neat. And then again, dermospherepodcast.com looks like this. So if people do ask you about it because you're wearing a button or for other reasons, you can tell them this would be a good place to go as well.
All right, so I'm doing the cow this morning. We have a 37-year-old male, previously healthy, who was admitted to the ECU earlier this year for a pruritic eruption. He said 10 months prior he had pruritus on the extremities, and then soon after he developed this erythematous papular eruption, started on his lower extremities and then radiated to his trunk and upper extremities. He says that the pruritus worsened at night, kept him up at night, and then that hot showers would worsen both the pruritus. 5 days prior to his presentation, he did develop more of a confluent erythematous plaques on his extensor surfaces. He was seen by several dermatologists, treated with topical steroids, antihistamines, antibiotics, treated with permethrin, with little improvement, and then he had several tapers of oral steroids, which did improve his lesions, but then once he got off the steroids, it flared. He had a biopsy in May of 2019 on the abdomen that showed folliculitis. Like I said, he was perfectly healthy. He denied any autoimmune conditions, including blistering diseases. Review of systems was remarkable for chills and mild night sweats. So here we can see he had these erythematous papules and some nodules with some excoriations and hemorrhagic crusting scattered on the trunk, extremities. Here we can see on the buttocks, lower extremities, and here we can see on the extensor surfaces with extension to the lower extremity as well. He had these confluent erythematous plaques. No cutaneous vesicles, bulla, or burrows, no oral ulcers, no involvement of the genitalia, and he did not have any cervical axillary or inguinal lymphadenopathy. So I decided to do a biopsy of one of the papular lesions and one of the plaques. So at the papular lesion, there was some acanthosis, some epidermal erosion, and some fibrosis, and the dermis more consistent with excoriations. But the confluent plaque showed a superficial deep perivascular lymphocytic and eosinophilic infiltrate in the superficial deep dermis, which was consistent with a hypersensitivity reaction. This biopsy also had some prurigo and frictional changes. So I talked to Dr. Floro reviewing these slides, and we decided to pursue a pruritic workup. And so his LDH came back as 497, and his rest of his labs were within normal limits. We got a chest X-ray, and it's hard to see from here, but there is an opacity here at the right lung. There's a well-circumcised lobulated opacity projecting over the right hilum that was consistent with lymphoma. So I referred to oncology. They did a CT scan and a PET scan. And so they showed a large mediastinal mass. Here you can see it's 120 millimeters. Features consistent with lymphoma. There's an extension into the anterior chest wall and encasement of the left subclavian vasculature. PET scan showed extensive mediastinal infiltrate involving the superior mediastinum, aortic nodes. Additionally, there's right hilar nodular involvement and some bilateral axillary and supraclavicular involvement. So general surgery did a right axillary lymph node biopsy. They found classic Hodgkin's lymphoma, the nodular sclerosis type 2B, and was unfavorable. He received 2 doses, 2 cycles of chemotherapy, and then they did a repeat PET scan. And you can see this mass has significantly reduced in size. His PET scan showed resolution of all metabolic activity within all previously identified sites of tumor involvement. No new sites of tumor involvement are identified. So I've been in touch with the patient. Patient's rash has resolved, pruritus has resolved. He had some diaphoresis and dyspnea when he was being evaluated by oncology, and that has now resolved. So this is an example of eosinophilic dermatosis of hematologic malignancy. Jack is an expert at this point. So I looked into the literature, and this condition is associated mostly with CLL, and it has been associated with B-cell leukemia and lymphoma. Interestingly, though, most of the cases, or all of the cases, have been non-Hodgkin's lymphoma. There have been no reported cases of Hodgkin's lymphoma. So just a quick review. Eosinophilic dermatitis of hematologic malignancy is a hypersensitivity reaction. They usually present with a generalized eruption, erythematous papular nodules, plaques, or patches that involve mostly the lower extremities, upper extremities, with some involvement of the trunk, and then less likely the face, scalp, and neck. 1/3 of cases in this review in Italy showed that biopsy was consistent, showed blistering which resembled BP, but when they did a DIF, it became unremarkable. So pathology here, again, consistent. It usually shows this superficial and deep perivascular lymphocytic and eosinophilic dermatitis. Also can present with spongiosis, consistent with arthropod bites as well. So treatment is treating underlying malignancy. However, most of these patients have underlying malignancy that doesn't get better. So there have been cases where patients have tried other treatments just for the meantime, such as doxy, UVA, cyclosporin, dapsone. Unfortunately, these have not shown significant improvement. These patients do improve with systemic steroids, but like in my patient's case, once you taper off the steroids, the eruptions reoccur. There was a JAD case report in 2009 with a patient with CLL. They treated the patient with Dupixent, and after 2 injections, you can see on the right here, he had significant improvements with Dupixent. So they were hypothesizing that the IL-4 pathway is involved with this dermatosis. So that's it. There was no peripheral urine. I believe you can see it in the diagnosis, yeah. The patient, CBC was, he had like a 2.5 on his white count.
How do you differentiate that from like an eosinophilic?
Yeah, presentation.
If someone had Wells syndrome and medically, they probably have DHM.
That's hilarious.
So I guess I don't understand. Is this a diagnosis that can be made on histology and biopsy or not?
No.
So it's the biopsy shows
It's terrifying.
eosinophilia or eosinophils in the tissue plus a malignancy.
Yeah, an exclusion of other causes. Yeah.
There's nothing very characteristic about that biopsy, right?
No.
For this was described, I'm sure in this patient skill elevation.
The reason why we pursued that was
This question the same day?
I saw it as a UIP. I saw it with Dr. McKenzie in clinic. The reason we pursued the pruritic workup is he had these like prurigo changes and frictional changes on pathology. And so Scott mentioned considering pursuing a pruritic workup. So he had it for about 10 months. Initially it was pruritus, and then he developed this eruption.
Yeah, we were just mentioning we don't always get an LDH in these people that have this pattern. So we're just saying, should we consider that in these patients a little bit more?
Huh?
Might as well.
Oh, do your thing. They're not expensive. Okay. Eric, stop talking. I'm going to start. Abram promised me that would be short, and it was too interesting. Okay. So, today I apologize in advance. I told Christina that I had an epiphany this week, and my canned presentation that I gave at Vanderbilt in December, I decided to completely redo since Wednesday, and so I finished it at 1 this morning. No conflicts of interest. Okay, so let's talk about some objectives. I'm going to talk about some key concepts about patient-centered research, some barriers to what we've experienced here in Utah with patient-reported outcome implementation, and then I decided I really want to focus on real-world examples so that you know how I use them. Instead of me saying, this is fun, this is nice, you should try it, I want to show you how I actually have used it in the last week or two. These are my brother. If there's pretty pictures, it's my brother who drew But first, I had to change subjects and share this lovely article from one of my buddies at Harvard. The patient's, they say ability, but it's really the patient's inability to interpret dermatopathology reports in an academic dermatology practice. We have to know this study because it is so lovely and well done. The premise is, can patients read dermatopathology reports? Their concern when they started this was there's specialized vocabulary, and then patients will call, not when you want them to, but when they see the results with their questions. This was at Brigham and Women's, and there the final path reports go to the doctor immediately, and then they have a 3-day hold before it goes to the patients. So what they did is they created a survey where they look at patient sex, age, education, their frequency of their MyChart use. So from now on, I'm going to say MyChart. And then Likert scales for how comfortable the patients were with computers for healthcare-related activity, how confident they were in understanding their test results, and then their preference of whether they prefer hearing from us as physicians or looking up their results online, and then their confusion or their understanding of looking up their health info online in general. Here is the actual path report that they used in their survey. And what they did, this is just ingenious because it was a real path report. This was the clinical. It was a chest lesion, shave biopsy, clinical diagnosis was nodular melanoma. The actual diagnosis was lobular capillary hemangioma, ulcerated and inflamed. And they had patients circle what was the diagnosis. 225 patients, 84% of them had at least a 4-year college degree. So these are not typical Americans. These are highly educated Boston elite who think that they know a lot. This is why I love this study. 70% say that they're on their MyChart at least monthly. They confirm that they have a high health literacy and that they are very comfortable with seeing their results online. So how'd they do? Awful. 12% of them circled the right diagnosis. 12. 62% though said this was really easy to understand. 92% worried. And then what was cool was 8% that were not worried. 4 of them circled that melanoma was the diagnosis. So I have to go through their conclusions word for word. While transparency is a worthy goal, it cannot be realized by simply sharing health information without offering context. Due to CMS rules, pathology reports should be redesigned to be easier for patients to interpret, including auto-generated definitions, bold titles, and clear lay language. Without such language, providing patients access to interprofessional communications may lead to confusion, heightened anxiety, and increased administrative burden. We haven't seen any of this, but I think it's coming. I'm just kidding.
Don't get me started.
Same paper, though, or same issue of JAMA Derm was this paper, National Survey of Dermatopathologists, on what do they think about patients looking at their path reports online. Here's where I see the University of Utah has an opportunity, because 56% of dermatopathologists said if patients are looking at their path reports, they're not going to change a damn thing. They don't want to change abbreviations. They don't want to change their specialized terminology. 72% said that they're not going to change how they describe their lesions. So there's an opportunity here. We could easily create some auto-generated text for basal cells, squamous cells, SKs. We could at least say this is benign, this is malignant, this is talk to your doctor, because this needs to be understood. Keith.
Pathology reports and radiology reports are meant to be done.
Okay, that's what they said. They said this is interprofessional communication. the problem is CMS said, screw that, give patients results.
They have results, but they're
No, that's not what CMS said. They said, do this or we're not getting paid.
Yeah,
And so if we don't change, we're just going to get more
this is where I
patients
think
calling
this is where I
about
think doctors
melanomas
really need
that
to
were...
step up and say, this is the way this is designed. There's specialized language in here that takes 15 years of training to understand and interpret for people. I don't think
And
we
a
can
college education isn't enough.
I don't think we can be pushed around by CMS for these kind of things. We can't dumb down our reports.
Interesting.
The other thing I think is that when you don't have your doctor interpret your report, then that's the opposite of personalized medicine. What's this big personalized medicine thing when you can't even have your own results reviewed in context of your health situation?
Believe me, I agree with you guys. That's why I wanted to present
Well, that's
this
why
data.
I think stick it to them. Don't give them any more information.
At the risk of making the dermatopathologist
I got a fire
mad.
started.
You did. So at the risk of making
Last
the dermatopathologist mad, if CMS is wanting patients to get their results as soon as possible, either we can auto-generate definitions in the DERMPATH report, even if we don't need them, or you force the clinicians to be on MyChart and act and be in touch with their patients ASAP. So I think that the auto-generated definitions in the DERMPATH report is a less onerous way of doing this than forcing the clinicians to constantly be checking to make sure their patients aren't getting results before they have a chance to call them.
So how are we supposed to describe a rash? I mean, you know,
I agree. Spongiatic dermatitis.
There could be, you know, the word carcinoma means a malignancy, and then everybody's going to freak out.
Yep.
You know.
No, I agree.
And
this
then you
is
have a
not
nevus, which
easy.
technically is benign, but we qualify them, and you know, I mean, there's the gray zone. It's ridiculous. Patients shouldn't be getting these. I mean, don't get me started.
What if we put something on the path report that says, wait till your doctor calls you about these?
Well, it's just ridiculous. I mean,
Yes.
you've already heard my story about, you know, the thing at the bottom of the report. A patient got one from Intermountain, and at the bottom there's the disclaimer about, you know, the lab and all this stuff. And in there somewhere, there was something about HIV testing. And this patient called Doug Woseth and said, I almost commit suicide on the weekend because he was reading that. It had nothing to do with his path. And he's thinking he has AIDS. It's ridiculous. Wow. And these are the first study you showed, supposedly educated people. What if you have, like, you know, I don't have a high school, I can't even read. I had somebody else read it for me.
I believe you. I agree.
Try to interpret it.
Exactly. I'll say, All right, so now we're going to patient report outcomes.
Sorry, Aaron.
It's okay. I opened that door. Okay, we're going to start with the story of Grim. This is Grim. He had some trouble potty training. But a few months ago, my wife took Grim for a well child visit. I'll change that picture. My wife's concerns were two things. She needed a flu shot for Grim, and he had failed a vision test at school, and she needed to know what the next steps were. That's all my wife was there for. The doctor, well, MA beginning, had lots of general questions for the chart. Nothing to do with the visit. My kids are all body weight, failure, so they always review that and say, ooh, they need to eat more. And then, exactly, chub them up. And then for pediatrics, you have to do age-appropriate counseling to get the right pay for reimbursement. So there was age-appropriate counseling, which was completely irrelevant to my wife. It was just sort of boilerplate. Oh, make sure they don't do too much screen time and make sure they, it just wasn't relevant. So what was the result of this just beautiful interchange? The result was my wife canceled our other 5 kids' well child visits, went to urgent care for 5 flu shots, and said, I've got too much to do. I don't have enough time to do this 6 times. So my question to you is, has this ever happened to you in a doctor's office where you walk out and say, what just happened? I went in with these 2 or 3 things, and I have no idea what I got out of that. If you don't feel like this has happened to you, I promise it's happened to your patients. Here are some Press-Ganey comments. I felt that despite my concerns, the examination was not thorough. My scalp was not examined at all. I looked at this woman's chart. Not once was her concern, look at my scalp. I don't say, no, I'm not going to do what you're asking me to do. But apparently, I missed that mark. Another one, the provider was a condescending type. He seemed concerned about things that were none of his business. That's what happens when we start asking them questions that we think is relevant, but they don't understand. So, where is this mishap coming from? Angie Fagerlund, chair over at Population Health, she published this a couple years ago. 4,500 adults surveyed. Nearly 3 out of 4 adults on this survey admitted that they do not disclose relevant medical information in our face-to-face visits. And the reasons for it are they don't want to be judged. If you smoke and you know you smoke, or you vape and you know you vape, you don't need to tell your doctor that because they're just going to complain, tell you to stop doing that. And then I have had patients specifically tell me when I use PROs to ask them pointed questions saying, why didn't you tell me this? They're like, well, I was kind of embarrassed that you'd judge me if I complained too much about how bad this was really affecting my life. So patients just don't want to feel uncomfortable. Make that even worse, patients sometimes are new patients. They have 0 rapport with us. You don't just open up and go full honesty with strangers. How do we close this gap between the patient's agenda and the doctor's agenda? I would argue that one of the best ways we can do it is patient-reported outcomes. So let me give you 30 years ago this statement: skin diseases are not disabling, do not hamper self-care, and are not fatal. Nonetheless, they are important for reasons that geriatricians are usually unaware of. They spoil the quality of life. If you disagree that we are really treating patients' quality of life most of the time in dermatology, I really need to talk to you because I don't understand what you're treating differently. We don't have vital signs that we track. We don't have a lot of strict measures. We treat their eczema or their psoriasis or their acne until they say they're happy. We don't, or we just cut them loose and say, I'm done with you. Not recommended with Press-Ganey. Also, about 30 years ago, this was a great study of 2,000 adults with eczema and 2,000 parents of kids with eczema. They reported that half of them had work affected by their eczema. 1 out of 5 changed their career choice because of it. 3/4 limited their household chores. Back then, they said 20% said that their sex lives were affected. I've done focus groups to argue that that's probably much higher. They just didn't want to admit it. And then, this is great. Patient and parent expectations were not met 4 out of 5 times in their first visit, and only 44% were satisfied with their initial eczema treatment. So, in the mid-1990s, DLQI and Skindex, which are the 2 derm-specific quality of life measures, were validated. In 2000, Dr. Kruger came to the conclusion in one of his papers that quality of life measures are more important than BSA in psoriasis. And you can think about that with people with inverse psoriasis. You could have 1% BSA, but if it's in a special spot, it's going to be much more concerning to you than a couple of big plaques on your elbows and knees. Metrin in 2001, she took this original 61-question Skindex and validated the current 16-question Skindex. And then since then, we have had no limit to how many disease-specific quality of life measures there are. And I would argue that we need to cut it out. The European Academy, they published with a task force that clinicians need to use this to measure in routine clinical practice and then as a source of reference or a baseline. Since then, they've been kind of prolific and had 7 task force papers about how important quality of life is in dermatology. And then 2 years ago, Meg Krin gave the plenary talk at the AED on quality of life measures are a dermatology vital sign. From my BJD paper, we show here, I just need a reference point for you. Skindex goes from 0 to 100. 0 is it doesn't bother them. 100 bothers them ridiculously. Teenage patient with acne, they are bothered by this. Then all of a sudden, started isotretinoin right here in the middle, and within a month, they had noticed at least 50% improvement and close to 80% improvement by 2 months into isotretinoin. I'm sorry, I keep bumping that. Let me show you a couple of key things real quick. I'm going to skip through some of the data here. These are autoimmune patients. We kind of have some extra DH patients in this population, but pemphigoid and pemphigus. And what I wanted to look at is the data on self-reported flare at visit. One of the questions that's commonly asked is, are you coming in flaring? And about a third to 40% were reporting flaring. Here's something that's really cool. There's really no overlap between Skindex scores when you're flaring and when you're not. Here's where I see some value in this. Looking at Luke Johnson and his desire to do telederm, you may have had this experience where I've had it all the time. I think I'm the best doctor because I fix patients or they come back to me. And so then I have an opportunity to fix them again. If they don't come back to me, they must have gotten fixed. The problem is when Mathis started, we're the only 2 at Farmington. And so frequently, and it's usually me hearing Dr. Mathis's patients being presented by his MAs saying, well, he used to see Dr. Seacrest, but now he wants to try you. I think we just assume that we are fixing patients that don't come back to us, and I don't think we are all the time. And I think this is an opportunity that we could capture patients. If we could use technology to say, I wonder how this patient's doing, or they're coming from Rock Springs or Idaho, and you just send them a Skindex, we could have a checkpoint where if they score over 30 or if they score a certain percentage from their initial baseline, that can automatically trigger saying we need to get you back in because we're not clearing you up like we would expect to see you cleared up. Here's another proof of concept paper. So this is isotretinoin. I took 57 patients consecutive patients in my clinic who we prescribed isotretinoin for. Anecdotally, we know that isotretinoin works, but when they ask the one question that they really want to know, how quick is it going to work, I just hem and haw and say, well, some patients, they get better in a month. Some people, they take much longer, maybe a few months. I wanted to know, could we look at this with patient-reported outcomes and actually see and give them information about how quickly they get better. We broke them up by acne type, acne severity, whether they had scarring, and then we looked at their weight-based Accutane or isotretinoin dosing. The only difference here, which was shocking to me, because I thought there might be a gender difference between how much the acne bothered their quality of life. The only differences were because, in general, the female patients were lower body weight. Their weight-based dosing tended to be higher at starting and at ending. But the key result is that overall, the average score for Accutane patients starting Accutane is about 40. Within a month, it drops to about 20, and by 2 months, it's definitely below half of their baseline. The other thing to note is for anything that bothers people socially, so vitiligo, acne, visible rashes, hair loss, things where social consequences are involved because they feel like people are looking at it, your emotional score is going to be the highest subscore that you're going to see, because that's the one that's asking how much does this bother you and how much are you embarrassed by it. And this is one where it also dropped 50% in 1 month, and then by the second month, it was more than 50%. A key thing to note is that I thought that a lot of my patients get worse before they get better. We really didn't see that with our data, that if they do, it might be during that first month, but by the end of that first month when they come back in, they're doing better. So take-home points, we'll focus on this bottom one. Patients love expectations. If you set their expectations, you can change their outcomes. Data has shown that if you frame their expectations right, you'll improve how well they adhere to the regimen, and you'll improve their satisfaction with the treatment. If you go in and say, we can fix this, we'll get this cleared up, if you don't, you've completely failed. They've lost all hope in you. But if you go in and say, this has been going on for 3 years, don't expect by this weekend you're going to be completely clear with this regimen, but I do expect you to see improvements, and we're going to keep working together. I just had a patient yesterday who that framing it changed a whole lot for him. So in 3 years, what have I learned about doing patient-reported outcomes? I do think that we can fundamentally change how we care for our derm patients, but implementation is very hard. I found this picture from when my wife and I were married, and then I found this picture where my wife looks maybe a couple of years older. This is what patient-reported outcomes has done to me. She has had 6 kids. I have just had patient-reported outcomes. Implementation is super hard. John Cotter is the change management guru in business. He's at Harvard Business School. Companies change all the time, and change management is essential. If you don't change, then companies die. And John Cotter has done so much research on this. He said that there's 8 steps to successfully changing a system, whatever it is. And if you don't hit all 8 steps, you're going to fail. He doesn't say you may fail, he says you're going to fail. So, I don't want to have you guess. I'll just tell you that when we rolled out patient-reported outcomes, I think we hit 2, and that's being generous. We did not roll this out with an effective change plan in mind. We just, at the time it was Vivian Lee, she said, I want this, it's going to happen. We made it happen. But we didn't follow any of the steps to actually get buy-in, to get supporters, to get early adopters, and all of the steps that come after that, and we have not succeeded. And the reason we haven't succeeded is because you can't get someone to change what they do if their salary depends on not changing what they do. So if you feel like it's going to slow you down, if you feel like it's one more thing to learn, if you feel like it's one additional thing to the 30 additional things that people want you to do, you're not going to change. And it all boils down to incentives. I told the residents this recently, but we had dinner with Marta and Jules Lipoff several months ago, and we talked about treating AKs. And Marta brought up the point. She said, I think tomorrow, if they change at CMS and say we will not pay for any treatment of AKs, how we manage AKs would change overnight. It would not be like a gradual. It would be, these aren't that bad. It wouldn't be, these are precancers, we got to freeze and treat every one of them every single time we see you, because incentives would change immediately. This is how we're doing, and it's not going to get better because of COVID-19. Because I've had patients just this week who say, I don't want to touch that iPad. But we started at 6% in 2018, got up to 30%. We did great. We were doing great for a while. I'm happy with this, and I really would love 50 to 80%, but you can't fix the world. We just keep dropping, and I know it's going to get worse with patients declining because of the iPads. Next, what I learned is that patient-reported outcomes are completely uncharted territory for clinical use. And I'm going to use this example of clinical trials. For 30 years, we have gotten to phase 3 of patient-reported outcomes. We have tested them and validated them, and we know that they work to capture what we want them to answer for us. The problem is no one has actually done the phase 4 and tested them in the real world to see, do they actually do anything that we want them to? This was, ISAQOL is the International Society of Quality of Life. I went in the fall, and it was eye-opening because there are so many really good researchers in this field that have no idea how hard this is to put into clinical practice. And there are so many physicians there that want to use this and have no idea how you take an 87-question assessment that might be the best one in clinical studies, and you're like, I can't make my patient answer 87 questions every visit. This was a great example from Harvard in plastic surgery, and I was on the edge of my seat with this one. He has not published it yet, so this is all just from memory. But there are two major ways to address post-mastectomy reconstruction of the breast: implant and a flap. And what they have argued and debated for years in plastic surgery is which one gives a better outcome for the patient. We do this a lot in our own surgical and our procedural things, is what's the best outcome for the patient. So it was a multi-center trial with thousands of patients. They had clinical and demographic variables. They had physician variables, how experienced the doctor was, where they trained, OR time, complications, how the scar looked. Then they had these patient-reported outcomes. In plastic surgery, they have face Q, they have breast Q, they have belly Q. All of these Q assessments are the quality of life measures for plastic surgery. And then they had physician-reported outcomes, which, just like the PASI for psoriasis, physician-reported outcomes do not always match how the patient's experiencing it. The results were in a huge multivariable model with all sorts of remodeling. The only thing that was important on whether a patient was satisfied was their patient-reported outcomes. It didn't matter how good the doctor was. It didn't matter whether it was an implant versus a flap. None of that mattered. The only thing that mattered was if a woman liked her breasts before the surgery, she uniformly did not like her breasts no matter what the surgery was after mastectomy. If she did not like her breasts before the surgery, she uniformly liked the outcome of the surgery. He said this has shocked them in plastic surgery because he said, we've never really cared really how the patient felt. We've cared about all these other outcomes and think that we know what we're doing. So one last thing is I need to just give you examples of what I actually do in clinic. One thing I do in clinic is this goes into my patient's AVS, their after-visit summary. If you completed assessments for this visit, we are pleased to provide your scores below. We give them their scores with the dates, and then we give them an interpretation of their scores. Patients love it because we're making them do it, and they like to know where they're sitting. This was an acne patient. She was 33 a month prior. She had dropped down to 5, which means her skin was doing a whole lot better and was not bothering her. Same patient, in her clinic note, what I've added is I've added this language to my note so that for billing purposes, whenever I address this in my assessment and plan, this now counts as one of my criteria up in the HPI because I've explained what these scores mean. Emotional score is asking questions about whether it bothers, worries, frustrates, embarrasses, or annoys patients. Symptoms is obvious: itches, burns, hurts, or irritates their skin. And then functioning is how much it limits them, interacting with others, working, performing their activities, and showing affection. I don't want to talk about that. I'll talk about that afterward. That's a university-mandated depression screening. I don't ever use those. So real-world examples. 20-year-old female, 5-year history of acne with scarring on her face, back, and chest. I started seeing her in January 2019. 70 is a pretty dang high score for how much it's bothering. Remember, 100 is this bothers me all the time, every day. And then it goes down to 0. It doesn't bother me all the time at all. So her mom came in. Remember, she's 20 now, so she was 19 at the time. Her mom ran this appointment. Only option she gave her daughter was antibiotics. She didn't want her on OCPs. She didn't want her on isotretinoin. The patient started the doxycycline, and I have seen her repeatedly begging her to switch to something else because even up until August, she was definitely better, but she was not clear physically. She did not look clear at all. I just saw her on Tuesday, and she told me, I'm doing so much better than this last visit. And then I looked at her scores, and I said, no, you're not. What's going on? And that led me to say, why can't we do something different? And that opened the discussion to, I told her, you're 20, you have a body, and it's your body, and you're the adult now. You don't have to defer to your mom on this. And once I left the room, because I had to go grab something, she told my MA, she said, I've been wanting to do Accutane for ages. He just told me I can do Accutane. We're going to do it. I wouldn't have got that if I would have just listened to her and she said things are doing great. Here's another patient, 14-year-old guy. Mom was very concerned about his acne. This has never happened to you, I'm sure. He was not worried at all. Here's his scores from 2018. 0 is, I don't care. I sit down with these patients, and I'm sure it's going to show up on my Press Gainies, but I literally say, Mom, if you're going to jump in the shower with your son and put the cream and medication on, if you're going to go put their cream on right before bed, shove pills down their throats, we can do a big regimen. But he is telling me that he's not going to do this regimen. No matter what I do, he does not care. I haven't seen most of those patients. I'm assuming Dr. Mathis will see them back. But I did see one back recently. He's now 16 years old, and shockingly, his acne really bothers him now. And I look at the mom with a smile on my face, and I say, now we can treat him because he's motivated to do it. 67-year-old man. His mom died of melanoma on her leg. He came in with 3 raised bumps. I have seen this situation. It's all over the place. People are freaking out emotionally, or emotional is their highest, but it's not really that bad. This is one where it doesn't change anything I do. I say, well, that makes sense, and I just move right on. Last one here. This is a patient who had moderate to severe acne, 3-month trial of Doxy, and then back in January I transitioned him to isotretinoin, and yesterday was his 2-month follow-up, and it's following that same trajectory that I would expect. When this doesn't happen, when the numbers go back up, you can say, what's going on? And it's usually that Accutane dermatitis. They're starting to develop other issues from the isotretinoin that you can then address. What this has resulted in, here's a great example. This patient right here, he took the time to listen to myself and my wife and address the concerns we had very well. I'm not tooting my own horn here. What I'm trying to show you is this is a patient with Haley who had been giving all sorts of things for it, including a lot of stuff that made no logical sense to me by random people in the valley. And his scores were pretty high. Remember, the average here is like 20. So if it's above 20, I don't care what it is, this is bothering the patient. He came back a month later doing better, and his scores were much higher. And I said, what happened? And he said, well, I didn't want to be honest with you, but I was hopeless when I saw you last time, and I was worried if I told you how bad it was, I would be just letting myself out there without any They just don't feel safe. Patients don't want to tell you how bad it is. And he said, I figure I should probably let you know how much it's really bothering me since you're really trying to help. Okay? So, last things. What I'm working on now is I've decided to stop pushing everyone to do it. I would still love for you to do it, but I need to focus on making life easier for us. I want to get a single sign-on at check-in. We're working on getting one iPad. Patients fill out their HIPAA form, they sign their consent to treat form, then it rolls into a patient-reported outcome. If it's separate, it's just one more thing for the front desk staff to do. I want all our patients to get access to their scores, either in their after-visit summaries automatically or in my chart. And then we are going to, in the next 12 months, but it's been 12 to 18 months for the last 3 years, switch to Epic for our patient-reported outcomes. And this is where we can send them an email saying, can you fill this out? I just really want to know how you're doing. And this, we can trigger it to where it'll automatically send to our schedulers if they have a certain score. And then finally, I want to simplify the rooming process. At Vanderbilt, what they're doing is they got a consensus of their faculty on what good questions we should have from the patients that no one else can give us but the patients. Why not have the iPads do it instead of our MAs? History of transplant, whether they have had a skin cancer, family has had a skin cancer. Fitzpatrick's skin type is the patient telling us what their skin type is, so why don't we have the iPad do it? We can get this history, and then the MAs have much less to do when they're rooming. I'm starting a PRO consortium in dermatology. If we have the AAD in 2 weeks, I'm going to meet with these people, and we're gonna start the ball rolling. So, I ran way over. I'm sorry. It was Abram's fault. Yes, one question, and then we'll go.
What happens if they start connecting that to your reimbursement and your patients aren't getting better? That was the one thing, like, when you showed examples of, like, well, they weren't controlled in the first place, and now their scores are way worse, and you hear about primary care and the nightmares that they have with diabetes and everything like that. So
if they tie this to reimbursement, it would not surprise me because CMS does illogical things. I don't think we're there yet at all. That's one of the things I want to do with this consortium is I want us to work with people that are also doing it at other institutions so that we can kind of guide that initiative for dermatology rather than them saying, oh, and we want you to use this obscure quality of life measure because that's what someone said. I have had patients where they're on Humira for HS, and the insurance company says, well, we need the DLQI. And I said, I don't do that. I do the Skindex. Here's what it is, and here's how it works. And they've accepted that as showing improvement. I've also used it to argue, saying, look, the average scores are this low. This patient is really struggling with this. And if I have follow-up data, here's how much they're getting better or not getting better because you're not letting me switch to the treatment I want. Okay, let's go over patients, and I'm around all morning, so I can answer questions.
Wearing my pin. I just wanted to remind everyone that Dr. Glenn Bowen's service is tomorrow. It's at the Alumni House at 9 o'clock. We will have visitation with the family, so you're all welcome to come. Family will be there. There'll be some food. And then the program will be from 10 to 11. So I just hope you all can come and see you there.
All right, we've got about 5 minutes per patient, so seems like we should get started and move quick. So it looks like we'd like to start with, I think she was about 40, lady with hemorrhagic bulli in the mouth. She had some photographs. Is there a first year who would like to spend 30 to 45 seconds describing this for us?
I can do it. I'm holding the mic already. Okay, so on exam today, I'm going to go to the pictures from today. These are a little bit difficult to see, but you can kind of appreciate a white stria-like plaque there. Does the pointer work? Perfect. And then there's nothing on her hard palate today, but she said sometimes she has red dots there. And then on the other side of her cheek, you can appreciate a similar white plaque that she says are there constantly. But on exam previously, these are the red, petechia macules she gets on her hard palate, and then the tense hemorrhagic blisters that she gets on the lateral tongue.
In the interest of time, do we have path?
Ooh.
Yeah.
This was Path from Intermountain from about a month ago. This is on her right lateral tongue. So this photo this is taken from right about here. Not a hemorrhagic bulla. This Path was essentially normal tongue. There was some glycosylation or glycogenation in the epidermis, and it was kind of tangentially sectioned. This was read at Intermountain as reactive, some mild reactive change, but we thought this was essentially normal here. There was a little bit of red blood cell extravasation submucosally that might be consistent with prior trauma, but otherwise this was essentially within the range of normal. No inflammatory infiltrate or any other significant pathology here.
Who biopsied this?
This was Dr. Wilson? Yes.
Where did you biopsy, Lindsay?
It was right here, according to the notes. Correct.
And she had some lab work done. I remember anti-centromere, and what else was relevant?
Yeah, so she has a history of Raynaud's and also celiac disease. She had the SSC antibody that was positive in the past, but that was prior to the development of this condition.
All right, so shall we develop a differential?
There's something called angina bullosa hemorrhagica that I've never heard of, but the picture in this case report looks exactly like what she has. It's associated with diabetes, hypertension, some medications, trauma. I'd never heard of it until I just Googled that, but y'all can type it into your phones too. The picture looks just like it. Angina bullosa hemorrhagica, rare benign disorder, sudden onset, painless blood-filled blisters, last 24 to 48 hours, which hers sounds like hers. So I don't know what I'm going to read the rest of this, but the picture looks like it.
I had never heard that disorder until Lindsay told me about it somewhere where we were standing.
I had never heard of this disorder. It's obviously just descriptive. It doesn't have anything to do with etiology. The thing that's really bothersome is that this lady has celiac disease. She has a good family history for it. She's had a child who's had a biopsy. She had serology. She never had a biopsy. I trust that she really does have celiac disease, and there are a lot of bizarre things associated with celiac disease, and I can't help but think that this might be associated with her underlying celiac disease, which at this time isn't that well controlled. She also has peripheral neuropathy, which can occur with celiac disease, and I think that overall, I think all of this is related to her general disease. That descriptive disorder that you had, Caroline, is just that. It says hemorrhagic bulli in the mouth, right? No, angina got in there, but whatever. Painful? Painful. Okay. I can't help but, as I told Lindsay, I can't help but think that this is related to her celiac disease. Pemphigoid, I've not seen associated with celiac disease. I've seen a lot of people with celiac disease. I just don't know what she has, but I would love to have to capture one of those blisters. That's what we need. We need to actually capture a blister, not whatever was biopsied there. And that's why I asked who biopsied it, because don't ever try to biopsy the soft palate like on the right here. If that's going to happen, have an ENT guy do it. Don't ever biopsy under the tongue. You can jab into the hypopharynx. It's not a good idea, although I do biopsy tongues, and we biopsy buccal mucosas. We don't biopsy pellets. She doesn't have buccal mucosa disease, so when she gets a lesion, she needs to have a biopsy, probably by ENT, of one of these lesions so that we really get a feeling for it, and we need to do DIF on that. And it probably would be a good idea to do a pemphigoid serology on her. Maybe the serology will show it.
The DIF was on the same site.
Anybody other thoughts besides biopsying a blister, maybe through ENT with DIF, as a reasonable next step? So ENT does the procedure, and we swing by and snatch the bottle away from them.
I can get people into ENT here the same day. But she's on IHC insurance. So
Daisy facilitates all right now.
well, she's on IHC insurance, so I can't.
Lindsay Wilson facilitates all right now.
I mean, that's what has to happen, is you have to get one of these lesions. But that's descriptive in the literature doesn't mean there's a cause.
I'm reminded of a case that Chris Hull showed me a few weeks ago about traumatic fat necrosis, and everybody says, well, there's no cause of this, and I suggested we check her for C1 esterase inhibitor deficiency, and that's what she had, since we know that that's associated with idiopathic paniculitis. So just because other people haven't been able to figure this out doesn't mean we can't.
Shall we move on to another patient? So next in our PowerPoint presentation is I think she was 70-year-old lady with pruritus. 74, she looks no older than 70. Who would like to discuss her presentation?
Okay, so this was an older woman who was coming in for an itchy rash that started about 2 years ago. She said it started on her belly, kind of around her umbilicus, and then spread to her bilateral upper and lower extremities. On exam today, she had scattered pink papules on her abdomen and her upper chest with some focal excoriation and hemorrhagic crust, some healing lesions. She also had these confluent erythematous plaques on her anterior shins, again with some focal excoriation, scattered pink papules. Her hands had less of these erythematous plaques and more just scattered single pink papules and some underlying erythema. There was some lichenification on the lower anterior shins as well. Her face was clear. There was some healing lesions on her upper back, and her feet were clear. I didn't see anything on her nail folds. Yeah, her hands were clear. She had a trigger finger on that left fourth digit, and that's about it. She had some rheumatoid changes, I guess, but.
We have Path.
Oh. So this was a biopsy that was done on her left forearm 1 or 2 months ago that was read here. At low power, not a whole lot going on. At higher power, you can see there is this kind of focal perikeratosis and crusting that looks impetiginized. There's some spongiosis, and then there are some scattered eosinophils in here. Let's see if I can find any of them. There's one. Yeah, there's a few eos hiding in there. So this was consistent with impetiginized subacute spongiotic dermatitis with those eosinophils, kind of the dermatitis differential to go along with that. And DIF did not show, it was positive just for some weak basement membrane zone IgG and then a little bit of IgA and C3.
And parts of her history? other relevant parts of her history? A few things, right?
I guess I'll describe it. So initially she came to me and it was diagnosed as allergic contact dermatitis, and I thought it was allergic contact dermatitis, and she lived with a cat and was allergic to her cat. So I tested her for that and it was positive, but getting rid of her kitty and changing her house around didn't fix anything. Oral steroids would reliably clear it, but she would come back in and say, it always comes back as soon as I'm off the oral steroids, even with topical steroids, and the sunlight makes it come out. And so I finally did an ANA and then this dermatomyositis panel and found that she had positive ANA and MI2 antibody, even though it always seemed more like dermatitis, and I still think with the path it is, but she responded to methotrexate, just 4 pills a week, and now she's clear. So, question is this dermatitis? What do we do with this MI2 antibody? She's had lung function screening, and that's normal. So I think we just watch it, but I wanted to bring her to see maybe what Jenny has to say about her.
So the MI2 antibody is supposed to be very specific. She sure doesn't look like she has dermatomyositis right now. So, whether you have cured her with the methotrexate, which will also help dermatitis, I think watching her, I don't know that I would treat her more aggressively if she doesn't have any other manifestations. Her lungs and muscles and everything else are clear. I agree. I think she looks more like she has dermatitis, but I wouldn't probably do more aggressive immunosuppression unless you can't control the dermatitis. Well, it sounds like you've done her lung screening, you've done muscle, and MI2 is usually associated with classic dermatomyositis that is treatment responsive, and less commonly associated with other systemic complications. I mean, malignancy certainly a possibility, and she's got a recalcitrant dermatitis, so working her up. But right now she sure doesn't look like a lady with dermatomyositis to me.
Other thoughts? So next steps, potentially just keep an eye on her, maybe do some cancer screening. Okay, and our final patient, 12-year-old boy. We do not have path on him, I'll tell you guys right now, but which resident would like to describe these findings?
So on his left first digit, we can see some longitudinal melanonychia on the lateral aspect of his fingernail. This was from photos taken at his clinic appointment last month. He also has some discoloration of all of his toenails except for on his left foot, the 4th toenail looks spared, and then on his right foot, the 3rd and 4th toenails appear spared as well. They have kind of a yellow-brown discoloration, and you can see some horizontal melanonychia with ridging, especially on the great toes. Today on exam, the pointer finger on the left hand continues to show the longitudinal melanonychia. It's evenly pigmented. He doesn't have any other findings on his other fingernails.
So this is my patient, and his mother described him as having nails that, quote, turn purple, and this condition affects various nails at various times. The patient plays soccer. When he came to see me, I thought it wasn't particularly impressive, and I thought it may be due to just melanocyte activation in the nail matrix brought on by trauma from soccer and things, and he had a mole or something in that toe. She wasn't real satisfied with that explanation, so I offered her the chance to come here and see if anybody has other thoughts. Dr. Mathis has other thoughts, and those of you at home will hear them shortly when he gets the microphone.
Is he smoking? Because it's in his finger and it looks external. Like vape nail, maybe? A new thing?
I did not ask him if he was smoking.
The toenails, I think, are from trauma. Like, just,
say again?
The toenails look like trauma, like melanocyte activation, because he plays soccer all the time.
So maybe he's a precocious 12-year-old smoker. I can ask him.
He is right-handed. He doesn't use his left hand for anything particularly repetitive.
Anything we need to be worried about? Something I'm not aware of? All right. Thanks, guys. And thanks from the family as well. Come down and get a Dermosphere pen or pin, and we'll see you guys next time.